Good evening, everyone. Welcome once again to the ILAE series of webinars that we've been conducting for the past 2 years now. And this evening, we are privileged to have Professor Jo Wimphorst, who is a professor of child neurology from the University of Cape Town. And she's also the director of the African Pediatric Fellowship Program. And she's the current chair of the ILAE Africa and a former president of the International Child Neurology Association. So today, Professor Jo will be talking to us about febrile seizures, which is a very common topic for most of the clinicians who are attending children and always brings challenges in providing appropriate management. So thank you very much, Professor Jo, for agreeing to give us this talk, and you're welcome.
Thanks, Edward. You guys see the slides?
Yes.
Awesome. Thank you. Okay, so welcome everybody, and thank you for giving up your evening to listen to this presentation. So this revisiting of febrile seizures came out from the recent African Epilepsy Congress, where the commission, chapter commission came together and talked about some of the presentations that had caused a significant amount of debate and discussion. And we realized that although this is a common scenario that we deal with, it still causes a lot of anxiety, and we felt that we should bring it up again to give people more opportunities to ask questions. And I hope you forgive me, but I have expanded it slightly because the reality in clinical practice, things rarely fit within a neat umbrella, and there's often other areas that we have to manage. So these are my declarations, nothing exciting. So what are we talking about? When we think about the definition and the implications of the epidemiology of febrile seizures, the whole definition is officially that it's a seizure accompanied by fever, a temperature more than 38 degrees. There should not be central nervous system infection. The age category to meet the diagnosis should be between 6 months and 6 years. And it's really common. It's the most common convulsive event in children younger than 60 months of age. This is what we would like to be managing. In fact, as specialists, we shouldn't even be needing to see this. So these are simple febrile seizures. They're under 15 minutes. And in fact, the vast majority of them are so quick. They're 1 to 2 minutes long. They should be generalized. The clinician should be able to find a clear focus of infection. And this is one of the critical mistakes that's made. To be a simple febrile seizure, there should be only one event occurring within the illness. However, complex febrile seizures, unfortunately, especially within the African setting, are some of the major challenges that we face. These are where there are prolonged febrile seizures. They may be focal, they're typically over 15 minutes, and they will recur often more than once within the infective period. There may or may not be focal neurology with it. So officially, about 70% of febrile seizures should meet the criteria for a simple febrile seizure, and some 30% will in fact be complex. This is data from resource-equipped settings, high-income countries, and we don't really have large numbers and good epidemiological data to tell us what the figures are within low and middle-income settings. But if we consider the etiologies, they are incredibly important in our settings and really raise the concern that in fact we may well be dealing with many more children with complex febrile seizures than would be seen in a resource-equipped setting. So our priority as clinicians is to make sure that we recognize what is going on with the child, so that we recognize where there may be an underlying CNS infection that would require acute intervention. This may be meningitis or encephalitis. And I've taken the liberty of slipping in some of the immune and post-infective causes because we must also consider these in the acute admitting child. So ADA, acute disseminated encephalomyelitis, is one example, and fires, so fever with refractory epilepsy, is another cause. We also, as clinicians, need to step back and look at the history of the patients presenting to us. Does the child, in fact, meet the criteria for having an epilepsy where the fever is a triggering factor? Could we, in fact, be dealing with either generalized epilepsy with febrile seizures plus, or even more worrying, a child with Dravet syndrome? So always think about this and ask those questions. And to remember that the impact of recurrent or prolonged seizures may well lead to a legacy of further developmental brain maturational problems. This is a wonderful landing page. It's used in the PET courses, and it comes from work by Lynette Sadler and Ingrid Scheffer. So when you're faced or consulted with a child who's had febrile seizures, stepping back and considering in the scenario that is put to you, where the child fits in these 4 possible categories can be incredibly useful for actually helping you decide what you should be doing with the patient. So the commonest scenario that you would hope to be dealing with is this setting here, where the child is within 6 months to 6 years of age and is having simple febrile seizures. In this setting, you should not be intervening, doing anything aggressive, and actually, they should not actually have the doctor doing anything to them. However, you may have settings where, in fact, there are prolonged seizures, febrile seizures, and this subsequently results in epilepsy, or there may not, in fact, be this scenario where there are just febrile seizures and eventually the child has epilepsy. You cannot predict this, you cannot tell, but it is important to be aware of this, and I'll allude to this later in the talk. These are the scenarios where you don't want to be caught out, the bottom 2 options. So this is where a child presents with apparently febrile seizures, but there's something not quite right about it. They're recurrent, they're prolonged. The underlying infection isn't enough to really explain why they would have a febrile seizure. And in these settings, this child may, in fact, have an epilepsy, and the fever is just part of the background. And these are classic examples of, on the milder side, where they may have genetic epilepsy with febrile seizures plus, and the more sinister side, where they, in fact, have Dravet syndrome. And these febrile seizures eventually, as the child grows, start to evolve into afebrile seizures and a true epilepsy syndrome. Similarly, you may be faced with a situation that, in fact, you know, so the child may have had early onset epilepsy that might have been related to a neonatal insult or an early onset epileptic encephalopathy. And as we often see in settings of being unwell, where there may well be a fever, seizures are often worse. I'm just doing a little side switch here when I said about other stories. This is one of them. So I alluded to Dravet syndrome. This is a terrible developmental and epileptic encephalopathy that needs early recognition and can be slightly improved with targeted therapy and early intervention. And the recommendations that came out from this consensus document highlighted that diagnostic approaches should be attempted. And I'm aware that in many parts of Africa, the genetic studies are challenging, but there are other ways of actually clinically making an assumptive diagnosis. You should be considering Dravet in developmentally normal infants between 2 and 15 months of age who present with a single prolonged hemiclonic seizure or a focal or generalized status epilepticus of unknown etiology in the context of vaccination or fever. We are missing these children, and we are missing opportunities for early intervention. Okay, so what can we do about management options for febrile seizures? Safety first. So in any patient that you're called about or you see, you want to go back and take a full history examination. Make sure that you don't miss critical issues that would direct you to an important etiology. So any concern of intracranial infection or an otherwise unwell child, you're going to admit them, investigate them, treat them appropriately. The tests that you do, the investigation, should be driven by the concern about the underlying etiology. And typically in our setting, this will be focused around excluding an underlying infection, especially a CNS infection. Antipyretic measures are completely appropriate. That is more for the symptomatic relief of the child. They will not protect against seizure recurrences. if you make the diagnosis of a simple febrile seizure, there is no indication to proceed and request an EEG or neuroimaging. However, in our setting, if you think there is a complex febrile seizure, think about doing the lumbar puncture, obtaining cerebral spinal fluid. So this should be considered where you cannot exclude CNS infections. So an infant with an unexplained fever, with meningeal symptoms, especially if there's masking with preceding antibiotics. Obviously, always checking whether it's safe to proceed with a lumbar puncture. If you've made the diagnosis of a simple febrile seizure, do not do a lumbar puncture. And my other slight deviation, because in our setting, we often don't get those simple febrile seizures coming in. But what we do get is children who come in with hectic, prolonged seizures, and fever is a major driving element of this. So when we look at the etiologies of seizures, when we consider the definitions, there's a time point T1, which is critical to be aware of. This is where there's failure of mechanisms that are responsible for seizure termination or from the initiation of those mechanisms. This is when we should be starting treatment. What we want to do is avoid reaching that time point T2. That's where you have long-term consequences and brain damage potentially occurring. So 5 minutes for convulsive seizures is your cutoff for when you really should be initiating therapy, because you don't want to reach that 30-minute time window. Sadly, many of the children that we manage actually present to us already at the 30-minute window. So it's already challenging. This data is based on animal experiments, but in fact, having this mindset and encouraging your emergency departments to consider it in their protocols sets really clear boundaries and is really, really helpful for units to just know that these are clear criteria of when I should be intervening for my patients. Because the issue is that although most seizures will stop within 5 minutes, if they haven't, the longer it takes to gain control, the worse your outcome will be, the harder it will be to control and terminate those seizures. This is often driven by the underlying etiologies, and in our setting again, many, many infections, but also preceding high doses of other therapies that have been given that haven't been effective. Mortality is listed as quite low here, but actually when we look at the African studies, it can be as high as 22%. And when we think about drivers within our setting compared to high-income settings, so typical presentations of status in a high-income setting will often be breakthrough from a child who's known to have epilepsy. Whereas in a low-income setting, this is where the febrile seizures really come into their own, driven by multiple infections and infective-related causes that are the typical drivers for these patients presenting to our units. And this data that was put forward by the FEBSTAT study team has been incredibly valuable. So it was a multi-center study in America. They pooled about 200 patients who presented to them in febrile status epilepticus. And their study question was in fact purely focused on whether there was a relationship between febrile status epilepticus and the subsequent development of hippocampal sclerosis, and by nature of that, subsequent temporal lobe epilepsy. But actually, with the study being done so extremely well and in so detailed, it generated a series of papers that have been incredibly useful for giving us really good foundation knowledge and guide about what would be safe practice for our patients. And these are some of the messages that are really important to take home. So an abnormal CSF is never normal. It always tells you that there's something sinister going on in the CNS. And that febrile status epilepticus seems to be a combination of lower seizure thresholds affecting younger ages at lower temperatures so that they are more vulnerable and have impaired regulation of seizure duration. So how can we be guided about the management of status epilepticus, and by nature of that febrile status epilepticus, in the children that we see? We know that level 1 evidence is strong for the use of benzodiazepines. That can be pretty much any benzodiazepine given pretty much by any route. Ideal would be IV lorazepam, The reality is that this must be kept in a locked fridge and is often difficult to access. And for the site of entry that many children present to, intravenous access may well be very challenging. So other routes are possible. What we wish to do is have 2 doses given if seizures are persisting. And we know that in the units that you work in, to use an agent that you have ready and sustainable supply of, that your team, your emergency team, are confident with using. Because in reality, you don't have to use just IV if that's not an easy access for you. So if you cannot get access to intravenous routes in the children that present to you, that shouldn't preclude you starting therapy. There's strong evidence to support intranasal midazolam, buccal midazolam. And again, in our setting, we often don't have the formulations that are used for oral use in high-income settings. So we use the intravenous formulation. It's slightly more irritant, but it works just as well. Likewise, comparative studies have shown us that it is as effective as intramuscular midazolam, and in fact, even compares to rectal diazepam. But if this hasn't worked, if your 2 doses have not controlled the seizures, then you're into level 2 intervention. And in our setting, typically the agents that we use will be phenytoin or phenobarbital. The problem with phenytoin is that it should be given over 20 minutes with a cardiac monitor through a large vein and not mixed some glucose. And I can't tell you how many times I've walked into emergency units and seen it given in a giving set and just pushed in. This is dangerous, and we need to ideally avoid this practice. For this reason, certainly in our unit, we've reverted to a preference to using phenobarbital. It can be given by a relatively fast push. There is bad press with this agent, that it can be associated with respiratory depression, hypertension. This is often driven by high doses of benzodiazepines and the underlying etiology. And in our setting, it certainly seems to work well. Both agents seem to be fairly well accepted. But again, a lot of this is on an anecdotal basis, especially with phenobarbital is concerned. And the studies that do exist have been quite small, with small numbers and less for children. This is a study that we did in my center, where we did a comparison of phenobarbital against phenytoin. And it was an open label, single randomized study. Of the 35% that proceeded on to second line intervention, in comparison with the 2 agents, phenobarbital terminated convulsive status epilepticus faster and more effectively than phenytoin. And we had less children admitted to the ICU in the phenobarb arm compared to the phenytoin arm. So what about levetiracetam? I'm sure you're all thinking, wouldn't it be wonderful to have ready access to it? So these are the 3 major studies that in fact were hoped would well and truly put it on the map and tell us that we should definitely have access to it across the African setting for management status. In fact, what they found was a pretty similar efficacy to phenytoin, and even with valproate. But they felt that the safety profile with levetiracetam was better, and certainly the ease of administration is much better. It's now part of the WHO EDL and has been promoted and supported to try and enhance us getting access to this agent, which is probably a lot safer to give in emergency settings than some of the other agents that we have to use. Those were all in resource-equipped settings. This is a very nice study that was published from India that in a similar manner compared phenytoin to valproate and levetiracetam, and in fact found no statistical difference in the seizure recurrence, but really highlighted that the long-term side effects, certainly with valproate, were more than with access to levetiracetam. If that doesn't work, then you're heading into level 3 intervention. And again, for many of our patients that present to us, this is the stage that they arrive in. This is disastrous. You're often dealing with resistant seizures. This may well be exacerbated by the underlying cause, such as an encephalitis, and then the secondary complications from what drugs you might have tried to give with hypertension and respiratory depression. And all of this is affecting the brain perfusion. So this in itself is very challenging. Okay. And then something else that I think many of us face is this frustrating situation of where we follow the protocols and we do the correct approach, but we seem to be faced with benzodiazepine resistance. And in fact, this is reported to occur in about 44% of children. And it may be that, in fact, we have a legacy of carrying a greater burden of this, because, in fact, in this study that we performed, we found that the longer the seizures had been occurring, the more likely it was that benzodiazepine resistance would occur, regardless of the underlying etiology. And by nature of this, not surprisingly, these were the children that ended up on our ICU and carrying a greater disease burden. When we also look at what you often regard as a resource-equipped setting and where surely things should work well, this was an incredibly honest report that was put through from one of those massive multi-center studies in the States, where the group went back and they cross-analyzed what doses were given of the benzodiazepines. So there was an assumption that they'd reached appropriate levels with the 2 doses of benzos that were given to enable them to enter the randomization for the next stage. When they went back and reanalyzed it, they found that the first dose of the benzodiazepines was lower than the guideline recommended, for 76% of those given Medaz and 81% of those given Lorazepam. And even more depressing, even the second dose was also underdosed. So again, this reverts back to have a protocol in your emergency unit and make sure that protocol works for you and make sure everybody understands the doses and how to give the doses that you are in agreement to give. So your child has had their febrile seizure. How are you going to manage them after you've stabilized them in that post-management care? So when should you keep them in for a longer period of observation? So if they're under 18 months, if it's a complex febrile seizure, definitely. If you can't find what caused the event, there's no clear focus of infection. If it's possible, they might have a partially treated meningitis, so they're currently or they've been receiving antibiotics. Or as a family are just really, really worried. And to remember something that we often forget in the enthusiasm of managing the patient, family need to be talked to, counsel them, ask their questions, check how they feel, check what they're worried about. They've gone through a terrifying experience. So one of the questions they might ask you is, understandably, is it going to happen again? And the simple answer is, well, yes, it's quite likely to happen again. You can give them a broad figure that about 30 to 40% of children will have a further febrile seizure after the first one. If they're accountants and they want something more precise, then you can do a little bit of quantification. So if the child is very young, then they're more likely to have a febrile seizure. If they're much older, then the probability goes down. And remember, taking out of that, if it's a complex febrile seizure, then all of this goes out the window because each complex febrile seizure must be managed in isolation. Other risk factors for your accountant families, if they give you a history that there's a positive family history, if there's been a previous history of febrile seizures, if the temperature was under 40 degrees, and if there was a short duration between the onset of the fever and the seizures. You can see here there's no risk factors, and you can say to them, oh, it's most unlikely, maybe 4%. If they've got all of them, you can say, yep, we're going to see you again. 76% chance it will happen again. So the question that often comes up, what happens if it's recurrent? What should I be doing? Should I be, in fact, be implementing treatment? So this was some work that we did through the Medical Therapies Task Force for the International League Against Epilepsy. And we took a series of common clinical scenarios, and one of them looked at febrile seizures and common settings that us as clinicians are faced with. And the case scenario that we put forward was you'd have a 14-month-old child, they're previously really well, but they've had 3 short-lasting, self-limited, bilateral tonic-clonic febrile seizures. They all occurred in isolation in the setting of a febrile illness, 6 months, 8 months, and 13 months. And the question that the parents are asking is whether medication is necessary, and if so, are you going to start a drug? So this was put out to a survey, and we got responses from over 450 people. And interestingly, 19% said that they would start an antipyretic medication, specifically to reduce the risk of febrile seizures. Just going to let you think about that. And then we'll unpack it a bit more in a minute. 4% were going to start regular or chronic anti-seizure medications. I'm hoping that I'm hearing a silent gasp from all of you. And about 40% wouldn't use any anti-seizure medication, would reassure the parents, and would discuss when to seek emergency care. Please imprint those last 3 statements. But it's very hard, because when children present with recurrent febrile seizures, the events often result in the caregiver being incredibly distressed and demanding that something must be done. And when the events are recurrent, the management, in fact, becomes more contentious. And I'll remind you of that diagram with the 4 lines of possible diagnoses. And the role for anti-seizure medications is debated back and forth. And in fact, there's a lack of consistency in recommendations in the guidelines that are out there. So the Japanese have really probably put the most work into unpacking and trying to decide an approach. And in fact, they used to have a very aggressive approach with early use of benzodiazepines and even anti-seizure medications. This has evolved, and their updated guidelines in 2017 are far more tempered, but I'll show you how carefully they've thought through. So they state that prophylactic benzodiazepines, certainly diazepam, is not routinely needed in children with a history of febrile seizures. They found grade C evidence to support this, so relatively low quality evidence, but they felt this was a safe approach. However, they did acknowledge that a prophylactic diazepam could be used in the following criteria. And for this, they actually had a grade B for the evidence of the data. So where you have a history of a prolonged febrile seizure, so it's lasted more than 15 minutes, and where you've had repeated febrile seizures, and in their setting, they felt this was more than 3. This was in association with 2 of the following risk factors. So the events are focal or repeated within 24 hours, that there's pre-existing neurological abnormality or developmental delay, a family history of febrile seizures or epilepsy, the child is younger than 12 months, seizures within 1 hour after the onset of the fever, or the seizures occurring with a body temperature less than 38 degrees. So just to then unpack this, those criteria do not align with simple febrile seizures. So simple febrile seizures, even if recurrent, you would not be doing these interventions. So these criteria align with where you have an unusual setting, something more complex, and where you would be potentially questioning an actual diagnosis of epilepsy. So what they concluded was that regular use of anti-seizure medication is not recommended in children with a history of simple febrile seizures. But in their setting, they felt that children with prolonged or repeated febrile seizures, despite the use of rescue diazepam, could have regular use of anti-seizure medications considered. And again, this is highly contentious. So looking at a Cochrane review that was published in the same year, they pooled a massive number of patients, and they found 13 studies that looked at interventions of continuous or intermittent prophylaxis of agents. They admitted that there were huge limitations in the methodologies for most of the studies, with the result that on their graded analysis, there was moderate to poor quality data. But they were confident enough to conclude that there was no significant benefit with interventions of intermittent phenobarbital, phenytoin, valproate, pyridoxine, even ibuprofen or zinc compared to placebo or no treatment. Similarly, they found there was no gain when initiating therapies at the start of a subsequent febrile illness in children with a history of febrile seizure. So some practices had been that a child who'd had a febrile seizure, the second they got a temperature, that they would then be given a benzodiazepine at that point, not when they were even fitting. So many of the reasons against this is that there are lots of side effects and you could potentially do more harm than good. And the document really highlighted that adverse events were in fact significant. So we know about the cognitive concerns about children managed with phenobarbital. In fact, those original studies were in children with febrile seizures, and the drop in IQ did not recover with removal of the phenobarbital. Adverse events, when pooled, were evident in 30% of children on phenobarbital and 36% of those in the benzodiazepine group. So the general consensus of use of anti-seizure medication trials found to be a poor methodology. However, the conclusion was that this was not a good idea. So they then did a follow-up, and in 2021, they found very, very similar findings with adverse effects in up to 30% of children one study that looked at levetiracetam as a possibility, and more studies were suggested. But actually, the core message that came through was not to start anti-seizure medication, but to revert to counselling and supporting families appropriate, that adequate contact details with medical services should be provided, that information should be given to them on the risk of recurrence, that first aid management should be talked through with the family, and most importantly, as they called it, the benign nature of the phenomenon should be emphasized. So when we look at overall guidelines that have come through, the consensus is that the regular or intermittent anti-seizure medication is not recommended. Simple febrile seizures are not harmful. There is in fact a high risk of having more adverse effects from being on anti-seizure medication, and in addition, a risk of masking a potentially informative clinical features. So what about those antipyretics? So this is a great study that was done in Finland, where they had a contained population. Nobody gets out of Finland because it's the hardest language to speak. And when they looked at over 230 children, they pooled them between either having an antipyretic or placebo. And what they found in the group was that febrile seizure recurrence occurred equally in both groups. And so they emphasized the fact that you can't counsel a family that putting the child in antipyretics will stop febrile seizures occurring in the child. If it's going to happen, it will happen. They weren't saying don't give the antipyretics because we know how horrible you feel when you have a fever. They were just saying don't give the family a hard time about why a febrile seizure has recurred, that it won't be because of the speed with which they implemented an antipyretic. So what about prevention of epilepsy? In fact, there's no evidence to support that any of the acute interventions that might be done would prevent the subsequent development of epilepsy. So families will probably ask you, then what is the risk of my child now going on to getting epilepsy? And the reality is that for the majority of febrile seizures, there's absolutely no association with the development of epilepsy, that you can really be very reassuring. There is a 3% risk of it occurring by 7 years and 7% risk by 23 years of age. And this is marginally increased on the general population. In the setting where you have, for your accountants, prior abnormal neurology status, a history of afebrile seizures in the first degree relative, or complex febrile seizures, you can accumulate these and actually quantitate it for the family and give them the different risk status to help them. So what advice should you give to those parents before you let them go home? Talk to them about seizure first aid advice, because you may well have that 30 to 40% chance of recurrence. Tell them that they should still give antipyretics with a fever, but tell them that it won't necessarily stop a further seizure occurring. And then one of the biggest mistakes, especially that's led often by the nursing fraternity in the emergency unit, is that in fact you should not be putting fans and cold baths on these children. All you do is cool down the peripheral temperature, and the body then potentially drives up the core temperature, and you potentially make the situation worse. If you're worried that the seizure was prolonged, offer rescue medication and talk it through with the family. And we would encourage this if the seizure by being prolonged was longer than 5 minutes. And then emphasize to the family that this event should not preclude the child proceeding with their immunization schedule. It should carry on regardless. The safety of the child is paramount, and this is a major factor for their safe life practice. Who should you think about following up? Definitely those that have had more than 3 febrile seizures in separate illnesses. Children who are presenting below the typical category for simple febrile seizures, so below 6 months and over 6 years. If they've had a febrile status epilepticus event, if they've got focal features, if the seizures were not tonic-clonic. And your focus, your attention and your priority in these children presenting should ideally be at terminating that seizure, to ensure that you're not missing critical differential diagnoses, to consider these and to focus your investigations in the acute setting on what the fever etiology might be, to provide adequate counselling to often very worried families. So your clinical approach and prognosis for the febrile seizures, in fact, is driven by the subtype of the type of febrile seizure that the child presents with, whether it's complex or even febrile status epilepticus, This will clearly require closer care than the vast majority of children who in fact present with simple febrile seizures, who will have excellent outcomes. So overall, it's important to remember that febrile seizures are in fact the most common convulsive event in children under 60 months of age, but that simple febrile seizures have no long-term impact, do not require investigation, that most children in fact won't have recurrent seizures, so they're unlikely to have more than 3 seizures, and most children will not develop epilepsy, and that you should be ideally avoiding starting anti-seizure medication prophylaxis. It is not required, unless in fact you're questioning a diagnosis of epilepsy. You should consider rescue medication for the safety of the child where they've been having prolonged febrile seizures. Thank you. And I'll stop with that and hand over to Edward for any questions.
Thank you very much, Prof. Joe, for a very wonderful talk on a very important topic, which is a common presentation for most clinicians. So now, if you have any questions, please put the question on the
I think we lost Edward, but I can see some questions. Are you back?
Have
you got them?
Them to the presenter address. So, yes, so we already have a few questions. So the first one, so a complex febrile seizure is defined as lasting more than 15 minutes. Status epileptic. So
I'll read it out of us. Edward, you're dropping in and out. I think your internet's going a bit wobbly.
Not a complicated seizure. Is the difference between the two? Fever, protect. Can you hear me now? So there are a couple of questions from Northland. So the first one is status.
I think we lost you again, Edward.
Yeah.
I'm good. Edward, you fell out again. We lost you again. Shall I just read the question out? Is that okay?
Can you hear me now?
You keep coming and going. Do you want me to read the question out? Because you keep dropping in and out, and I don't think anybody's heard the whole question. It's a really good question. Is it okay if I repeat it?
Yes, just read the first one,
okay.
And then I'll try to sort out my network.
Okay, cool. That's great. So the first question from Dr. Ngorbo is: a complex febrile seizure is defined as I will, yeah. So a complex febrile seizure is defined as lasting more than 15 minutes. Status epilepticus, more than 5 minutes. Absolutely correct. You are completely correct. So is status not a complicated seizure? So status epilepticus is indeed a very complicated seizure, and it is a reflection of a management need where there may be multiple other underlying factors. The issue of recognizing status is that you need to be considering when you should be doing a therapeutic intervention with anti-seizure medications in the acute setting. But your issue of considering a complex febrile seizure is that you want to make sure that you've actually considered what the underlying etiologies might be. So I hope that answers it. So the next thing, are all atypical febrile seizures attributed to syndromic causes like Dravet or febrile seizures plus? No. Unfortunately, in our setting, many of them are related to infective causes, in fact, and they're probably by far the main ones. And that's why you've just got to be a little bit canny to consider where, in fact, there might be an epilepsy syndrome as well going on. And then the issue about using levetiracetam. To be honest, you saw the efficacy for the level 2 interventions. You need to use the agent that is routinely used for level 2. And in our setting, that's going to be either phenytoin, phenobarb, possibly even valproate. I don't particularly like valproate, but it's definitely used in some centers, and levetiracetam. You need to be using the agent that you have reliable supply of, that you can give properly. And in the acute setting, the issues of the concerns about paradoxical responses, for example, to different epilepsy syndromes, actually becomes null and void because you're dealing with the acute management of the patient. Okay, in the definition is the recurrence of the seizure within the same untreated Febrile, in the definition, is the recurrence of the seizure. I don't think I understand that.
I'm back
Dr.
now.
Ben-Kieran, are you?
Yes.
Can you understand this question? Because I think I'm missing
Yeah,
in
I
the
think what
definition.
okay.
Yeah, go
Yeah.
on.
Can you hear me? Yeah. So in the
Yes, I can.
definition is the recurrence of the seizure within the same untreated febrile illness, an item for complex febrile seizure. I think it's asking if you have one illness, and then you have more than one event of a febrile seizure, whether that forms the definition of a complex febrile seizure.
It does. So yes, yes, yes. I mean, it's very worrying that there might be something serious going on. Excellent.
Yeah.
Okay,
So the
next
next one.
question.
Yeah. So sorry. So what will be the best approach for a case of an infant who is brought in at OPD with first onset, brief generalized tonic-clonic seizure?
Associated with a fever 12 hours ago,
Yes,
overnight.
overnight.
And
Yeah.
now he's,
He's
oh my
now
word, and now
presented
he's
with
coming in. Go on.
bulge anterior fontanelle, but he's otherwise well, febrile with no neurological deficits, and septic workouts are otherwise normal.
I treat him for meningitis. I wouldn't do a lumbar puncture. What would you do?
Yes, I agree. Yeah, I think this was a specific
Yeah.
one. Yes. So next one, what's the incidence and duration to develop MTS? I think it means mesiotemporal sclerosis in febrile seizures patients.
Yes, that's a great question. So that's slowly coming through from the FEBSTAT studies, and what they're finding is, I don't think we can give you an incidence, and we definitely don't know within the African setting, but it looks like from their data, the kids that they scanned, the ones that had early changes on MRI in the hippocampal area, were obviously more vulnerable. So they could recognize in the acute setting that there was a proportion of kids who, and not all of them, who had changes in the hippocampal area that then went on and subsequently got temporal lobe seizures. So there's clearly more modifiers that make some kids more resilient and other kids more vulnerable to having it. And then in the American setting, because they present so early, they don't tend to have these prolonged episodes. So I think they'd have problems doing the study, whereas we wouldn't, because we have lots of prolonged cases coming in. So it remains a risk.
Thank you. So the next one is anti-seizure medication started? If anti-seizure medication started, for how long should it be continued? What is about definition of febrile seizure since 1 month of age?
Okay, so that's two questions. So for a start, you should only be starting anti-seizure medication if you are making a diagnosis of epilepsy. Okay, so continuous anti-seizure medication should only be started if the child meets the criteria for epilepsy, which simple febrile seizures don't. And even an isolated complex febrile seizure, you're treating the underlying etiology. And then a kid that's under a month of age with a febrile seizure, I would be extremely worried about an underlying epilepsy in that situation. So in that situation, I would be checking, actually, no, first of all, I would be wanting to make sure there wasn't an underlying infection, assuming that that's the cause. And then I would be wanting to understand if there was something more complex going on, because that doesn't fit between your 6 month, 6-year window. So it's immediately a red flag that there's something more sinister going on.
The next
Thank
one
you,
is
Seraphin.
my French, which I think is très belle
It's just,
presentation. So very
yeah,
good presentation.
it's saying thank you.
So
Thank you,
the next
Seraphin.
one, yes. So do you consider cerebral malaria a CNS infection?
Oh, that's a sneaky question. I should make Gretchen answer that. So the issue is it's complicated. So it's probably a continuum. So you may well have your acute presentation, and then you've got the sequelae with the inflammation, and then the children with malaria retinopathy. I mean, I think, Edward, I might defer to you about what you would do in that situation. You probably have more experience with that than me.
Yeah, so there are some studies which have been conducted which have shown actually children with cerebral malaria have an increased risk of having other bacterial infection as a co-infection together with cerebral malaria. So in most cases, you will start empirical treatment for malaria and infection as you investigate. And then if you find that there are no infections, then you can stop the antibiotics and continue with anti-malaria treatment.
Brilliant. Thank you.
And then the next one, and what about children with malaria without the malaria retinopathy? doubtful actual CNS sequestration.
Yeah, I don't know. What do you think?
So in most cases, like in our setting, we'll treat them if they present with altered level of consciousness, with a positive malaria test, either with a BS or with a malaria rapid diagnostic test, then we will treat them as patients with cerebral malaria.
Yeah, so you err on the cautious side.
Yeah.
Yeah. Do you want to say something about the studies with acute management with the phenobarbital? Because I think you don't do that, do you? Prophylactic phenobarbital before a seizure
Oh,
occurred.
no, we
You
don't.
don't do that.
We don't do
Yeah.
that. Don't do that.
So there's good evidence to say that's not a good idea.
Yeah.
Okay.
And then the next one, essentially when seizures occur from malaria fever, how do you consider this?
Yeah. I mean, surely in an endemic area, it's like top of your priority risk area. But I like what you said about co-infections as well. So where malaria is high, you would definitely cover and treat empirically, but presumably you would also keep a low threshold considering other co-infections. Yeah.
Absolutely.
Okay.
And just to add on that, so particularly in this setting where malaria is endemic, so patients with severe malaria may also present with fever and seizures. And in those cases, you will just treat the malaria. And then the other one is, I have a child aged 2 years having frequent simple febrile seizures and complex febrile seizures. First event at 6 months, development is normal. So far 7 events, and last 2 had a gap of 10 days. Parents panicked. Should I start anti-seizure medication?
I mean, I would revert that back and say, do you not think you should be screening for Dravet syndrome?
I agree. So it goes back to that slide that you presented about the different
Mm.
scenarios, and then revisiting whether that is just a simple febrile seizures, or possibly it's an epilepsy, which is presenting now with seizures and fever. So revisiting the diagnosis and then treating appropriately.
Mm.
The next one is, in terms of the effects of febrile seizures, social and emotional development impairment is often noted in children who had recurrent febrile seizures. These impairments have been shown to improve with CBT. So I think it means cognitive behavioral therapy.
Cognitive behavioral therapy, yeah.
Yeah, so would CBT help improve these impairments in children who receive benzodiazepines, since benzodiazepines can affect cognition?
Okay, so there's 2 questions here. Please don't give benzodiazepines beyond acute coping, and an acute management of benzodiazepines will not impact on the child's development. Chronic use will. And cognitive behavioral therapy, I've not heard of that being necessary in the setting of simple febrile seizures. That sounds very interesting.
I agree. So the next one is, thank you. So who is febrile seizures? I think it means, how is febrile seizures different from epilepsy?
So for that, I would encourage Dr. Kamara to go and look at the definition of epilepsy, which is potentially another talk, but febrile seizures are not epilepsy.
Thank you. And the next one is, if controlling fever does not prevent recurrence, why does seizure occur with fever in the first instance?
That's a great question. I think there are multiple different modifiers and factors that affect. We do know that the threshold in children, young children, is much lower. They're much more vulnerable, and that they will have a lot more active seizure activity for lower fevers that they can't regulate as well. But there are multiple different inflammatory processes that occur that will then trigger the fever, trigger the seizure to occur.
Thank you. So the other one, thank you for the wonderful talk. What is your opinion about oral drops, clonazepam, for preventing febrile seizure recurrences?
So this is the question, and in fact, the Japanese were very upset because they wanted to carry on using. They would start not just diazepam, but they would actually start clobazam at the beginning of a fever. So the recommendation is don't do it. So you can use whatever rescue therapy works well for you if you've got a child who is at risk of having prolonged seizures. to have them ready. And I get very anxious about kids that are, say, in rural areas and have got long distances to travel. But the actual benzodiazepine that you decide to use, it needs to be whichever agent works well for families. So we quite like using Ativan, and in fact, Ativan tablets that they can just slip under the tongue. But that would be done when a seizure started. So when they're basically into the seizure and it looks like it's going to be prolonged. So when the family are somewhere away, they're not near a hospital facility, and they're heading into that 5-minute window and they know what they're heading towards.
Thank you. So the next one says lumbar puncture, CSF in complex febrile seizure. Clarification, please.
So if you're worried about a meningitis or any infective process, you need to be considering whether it's safe to do a lumbar puncture. And if the child's actually too unwell to do the lumbar puncture, you need to be empirically treating them, be it cover for malaria, other bacterial infections, and even encephalitis.
Okay, so the next one says, if the child has had a temperature of 37 with the first time with tonic-clonic seizure, could we diagnose simple febrile seizure in this situation?
This often happens, hey? So sometimes it's a peripheral temperature that's been taken and the child's been put in like a bath. So it may be that temperature is not accurate. And it might have been that it has actually peaked before the child actually came in. So if there's a history of illness and of a temperature, although it might not meet the criteria, which is 38 degrees, then I think that you should have a low threshold for saying that you suspect that it's a febrile seizure.
So the next one says, great presentation, Prof. Is there a place for intramuscular paraldehyde in the management of status seizures?
I mean, the problem is that most of us can't get paraldehyde anymore. It's a really good anti-seizure agent, but I think it's more a supply, and with that, it's a loss of confidence. But again, in your unit, in your emergency department, you should have an adapted protocol that ideally aligns with international guidelines, but works for your setting.
Thank you. The next one is, can a child with febrile seizures develop epilepsy?
So there was the slide, which I suggest Dr. Juman goes back and looks at, that actually gives the fact that although it's unlikely, there is a very marginal increase, and it gives the figures for the risk factors for that in the slide.
Okay, the next one, any update on the dose of IV and rectal diazepam or IM midazolam? Second dose is still considered critical for respiratory depression. The interval between two doses, please. Any new data?
Okay, so you start giving treatment at 5 minutes because that's when you would, that's your T1. And then I never give doses because I would like a unit to look it up, because often there's different formulations and concentrations. So use whatever it says in the guideline that you have. And then the gap between is usually 5 minutes. So you would give it as a rapid push. You would obviously watch the airway during that time and have the child being monitored. And then if the seizures are still happening after 5 minutes, you would give that. Again, you'll find variances in different guidelines. So again, make sure that you follow the guideline for your unit that has been agreed upon by all staff. And then your dose will be right, your approach will be right, your formulation will be right, and your timing will be right.
So thank you for the talk. And then we use valproate quite often. Can we give quicker without ECG? What would be your greatest reservation on using it?
I don't think it's that good. I don't think the studies are that convincing. And my biggest anxiety, especially in our setting, is that often the kids that have been fitting a lot and have an infective drive, of course, have got abnormal liver function. And I'm anxious that if we then load them with huge doses of IV valproate, there are a number of case reports about hepatic encephalopathy and further liver derangement from this. And I think we've got better agents, actually.
Okay, next one says, what was regarded as repeated febrile seizure? Is asking, is it more than 3 episodes according to the Japanese guideline to warrant prophylactic anti-seizure medication?
Okay, so there's two questions there. So recurrent febrile seizures, there's no data or strong evidence to tell you what would equate to recurrent febrile seizures, because you might have a completely well child who's had, like that 14-month-old that I gave you the case illustration, that child has had 3 febrile seizures. You absolutely would not start anti-seizure medication in that child. So it's again situational. So 3 is the time when they would be encouraged to come under a service. And my take on that is to try and avoid starting medication, to give the family a place of safety, to monitor the fact that there's nothing atypical that's happening in the febrile seizures, that they're still remaining as simple febrile seizures, that the child remains developmentally well, that there's nothing else of concern, and that the family are confident in the care of the patient.
Okay, now question from, it's an interesting one. What is the best recommendation from a neurophysiologist to a pediatrician for which febrile seizures were confirmed on routine EEG?
Okay, so that's a very interesting message, because if the neurophysiologist confirmed febrile seizures, that's a miracle, because febrile seizures should have a normal EEG. And in fact, we really try to avoid doing EEGs on children with simple febrile seizures, because they often pick up incidental findings that are incredibly confusing and nothing to do with the child having epilepsy.
Thank you for clarifying that. Thank you for the great presentation. Will the recording be available? Yes.
Yeah,
in
will.
form, so you'll get a link, I think, from YouTube. Thank you.
Yeah.
For simple febrile seizure that is lasting more than 10 minutes, can we start anticonvulsant, or shall we wait for 15 minutes to see if it meets the definition of simple febrile or continues to become complex?
See, I think it depends if you're in America or here, because the Americans, I think, have the cutoff of 10 minutes. I have to say, I have always been quite anxious about the 15-minute window. I can't imagine sitting and watching a child fit for 15 minutes. So, in fact, the cutoff for starting intervention should be 5 minutes, because
Yeah.
you're managing status. But
Yeah.
your definition of saying whether it was, in fact, a complex febrile seizure, it depends again what unit you're in. Officially, it's 15, but some places will say 10.
Thank you. So how would you manage a child who presents with febrile seizures clusters, 1 year, 9 months, presented with a fever and an obvious cause, with plus or minus 10 short seizures, which are less than 90 seconds? Should we give a benzo or wait for 5 minutes?
So first of all, when it says an obvious cause, I would be deeply concerned about a meningitis or a CNS infection. So that would be my priority, to actually check what the glucose is doing and the fluids, and stabilize the child and start antibacterial and antiviral therapies and antiparasitic. And then for the 10 short seizures, for intervening, it sounds like you're going to have to, but it depends if the child meets the criteria where there's depression in their consciousness. So recurrent repeated seizures, you normally look to see whether they're not fully recovering between them.
Thank you. The next one is, can levetiracetam be used to treat prolonged seizures?
So levetiracetam, as you saw in the studies, in the setting of status, certainly febrile status, is definitely one of the agents which is used as part of the arsenal. But again, it would depend on your emergency unit protocol.
Thank you. How can we best treat children who present with first-time seizures of unknown cause, but later discover to have neurocysticercosis?
Are we veering off febrile seizures now? So I think we probably have to have another talk to do neurocysticercosis, because that's also a very interesting talk of when you start therapy or not.
I agree. Is mesiotemporal sclerosis prognostically significant?
Also an excellent question, because in theory you would only look for it if you'd actually had seizures. So the FEBSTAT study was very exciting, with the fact that it picked up children that were at risk.
Okay. Please repeat the reason why cold compressions are not efficient in a child with febrile episodes and seizures.
Thank you, Dr. Peter, for raising that. So if you cool the peripheral temperature, the core temperature reacts and actually increases. So by putting ice packs on the child or cold fans, you potentially exacerbate the situation.
Thank you. If all anti-seizure medications were started for recurrent complex febrile seizures, how long would you continue the treatment, or other words, how long do you aim the seizure freedom before stopping them?
So, Dr. Manchala, I want to emphasize again that in a complex febrile seizure, the focus would be on the underlying etiology, which in our setting, we would be most concerned about an infective cause. If we were concerned that the child, in fact, has an epilepsy or an epilepsy syndrome, then we would manage the epilepsy syndrome accordingly. And so then the child would be on longer term treatment. But that would only be in that setting. So in the setting of actual complex febrile seizure, then we would manage that and not start anti-seizure medication.
Thank you. The next one is, are meningeal signs hard to assess in babies below 1 year, or sometimes they are really absent? If a child
Totally agree.
if a child looks healthy and all 1 year free, should I monitor or do CSF?
Yeah, if you can't find an explanation for the fever, and especially if the child's had a febrile convulsion, febrile seizure, you need to assume there's a meningitis in infants because they can really mask it. I think we probably all had them sitting, looking actually quite happy, smiling at you, and then you touch that fontanelle and it's full and you realize there's something more sinister going on. So absolutely.
Okay, so I think this you've answered. Says, is it still acceptable to not to do a lumbar puncture if a child who's had simple febrile seizure and an identified source for a fever, for example, upper respiratory tract infection?
Yeah. Do not do a lumbar puncture, basically. Simple
Thank you.
febrile seizure, do not do anything to the child.
Thank you. Next one, it says, if a child with history of febrile seizure has multiple fever episodes associated with multiple seizures within 24 hours, each lasting less than 5 minutes, should these seizures be controlled with anti-seizure medications?
So two priorities. Your first priority is, what is the underlying cause? Are you missing a CNS infection or process? And then your management of the seizures should be acute. And you would probably want to look at whether the child is obtunded, if they're encephalopathic, and in that setting intervene with anti-seizure medication. But that would be for the acute management, not for starting long-term anti-seizure medication.
Next one says, what happens when febrile seizures for 3 days become afebrile without any drugs taken?
Oh my goodness, that sounds worrying. I would worry about an epilepsy syndrome, but I would still focus in the acute 3-day period on whether there was, say, an ADEM or an autoimmune encephalitis going on. But I would treat the child symptomatically.
Thank you. The next one says, how do you counsel parents on seizure first aid at home and school?
Brilliant question. So to warn them that it might well recur again, to ask them how far they are from a medical facility, to assure them that if it happened once, the chances are it would follow a very similar pattern, and then to make sure that the family have a plan of what to do with the child. For example, if they're post-ictal, putting them in the safety position, bringing them in to be checked over for infections, and just basically talking through any concerns they might have, asking them not to stick things in the child's mouth, and encouraging them not to put fans on or to put them in a cold bath, or throw water on them, the other favorite one.
Thank you. I'm not sure what Lorian means. He says, what other tests to perform in OPD when the EEG and CT scan are normal, even the electrolytes? I think maybe he's
So I don't
asking.
know. Yeah,
Yeah.
I think if he's talking about simple febrile seizures, you shouldn't be doing any of those. If you're
Okay.
talking about complex febrile seizures, again, it depends on which direction the history and examination takes you.
So thank you. The next says, what is the first treatment indicated in febrile seizure?
So I think they probably need to revert back to the talk, because a simple febrile seizure will be reassurance, whereas a complex febrile seizure will be driven by the acute needs of the patient.
Okay, I think this what drug to give to the patient for the first aid?
Yeah, again, that depends on what the preference is in the local setting. So in our setting, we do ativanol-lorazepam under the tongue. Other centres might well provide the families with vials of midazolam to do intranasal. Whatever it is, it's got to be something that they are confident with and that you can train them up confidently with and that they have appropriate and safe storage of.
Thank you. I think the next one is not a question. I think they're giving us their number, so we're going to skip that. And then the other one is, I think it's a statement. Febrile seizure is a clinical diagnosis, not an EEG diagnosis.
We totally agree with you. Thank you very much for emphasizing that.
And then the other one is, thank you so much, Joe. Great lecture. In the UK, no consensus or evidence for managing complex febrile seizures, but most trust guidelines recommend imaging for focal and an EEG.
So if it's a complex febrile seizure and you're worried about an underlying structural pathology, then that would be appropriate. And I think the PET guidelines do actually go into it quite well. And there's a whole tutorial on it that talks about safe practice. So it's all about the underlying etiology. That's the main focus. So, goodness,
Yes.
we generated and stirred up a lot of trouble.
Yes, I think we went through some 50 questions, so that was very good. I hope everyone had enjoyed the talk. And once again, I'd like to take this opportunity to thank Prof. Joe for presenting this excellent talk. We all loved it very much. Oh, there are 2 more questions. Oh, 3 more. Okay, maybe let's handle them before we close. Do you think that maternal factors such as stress, anxiety, gestational diabetes can affect the risk of developing febrile seizures? In addition, I might have missed it. Are there any community outreach programs to train the parents and family members what to do when their child is having a febrile seizure?
That's a brilliant question. So I'm not aware of maternal factors. I mean, certainly maternal factors place stress on the outcome for the infant, and there's no doubt that there's brain development issues that affect both the mother and the child. But the risk of actual febrile seizures, as far as I know, is an independent factor. And then community outreach, brilliant question. I think it probably varies in which part of the world you're in and what the facilities are. Ideally, it should be something where there's support from the NGOs. I wish we had epilepsy liaison nurses. I think that they would be phenomenal, and I think they would be brilliant in the African setting, but sadly we don't. So we'll keep plugging and trying to persuade that. But yeah.
Yes, so it's been an hour. So once again, thank you, Joe, for a marathon of a talk and a marathon of over 50 questions that we had to go through. So thank you very much for giving this talk. So we've come to the end of the sessions. And before we close, message for all participants: the Global Health in Epilepsy Project database provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. The database will provide you an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academia, nonprofit, philanthropy to learn about existing efforts while offering a means to engage. So once again, so thank you very much. Please complete the assessment through the link that is through. You can scan the QR code and then you can complete the survey. So you'll also be able to get your certificate for the for your CPD points. So once again, thank you very much for joining, and looking forward to see you again in our next webinar. Thank you so much. And